thoughts about genomic biomarkers or genomics in risk stratification of these patients? Are you using that in practice? Are you still thinking of this as, very researchy and not really applying to practice? How are you thinking about, genomic risk stratification in CSBC patients?
I can take that. For the most part, stepping back a little, kind of related, but I think for every patient that's metastatic, we always want to check germline somatic testing. But as far as for treatment decisions, looking for particularly a PARP inhibitor, but for genomic like gene expression profile testing or what is the ARV7 splice variant, I haven't used those in my practice. I'm not really I'm not really sure if there's a company. None of the ones that I use really test that regularly, and so that's kind of some interesting markers that might help predict for responsiveness to treatments. But no, I haven't used those in my practice yet.
Are you using a genome?
I agree with him pretty much. Definitely in the hormone-sensitive, not really much of a use at this time.
Just the BRCA2 subset. So we are looking at that. But we're doing genetic testing on new patients coming in. And I think it's going to change things in the future.
Yeah, I think that the field is rapidly evolving, and there's no consistent guideline recommendation to use genomic guided risk stratification in castration-sensitive disease. Correct. What I've been thinking about more recently is the data that has evolved in tumor suppressor genes as a marker to identify high-risk patients, and SPOP mutation as a marker for patients who are more sensitive to NHT alone. So sometimes what I do in at least in my thought process is, if there's a patient who has these high risk tumor suppressor genes, P53s, P10s, RBs, I tend to favor triplet therapy in those, like adding docetaxel on top of NHTs. If there's an SPOP mutation, I tend to think about just using ADT plus NHT alone in that setting. But you're correct, the data is evolving. Actually, we have a trial ongoing which is testing for genomics, and then if there is a HRR mutation, BRCA, and other related genes, those patients could get a PARP inhibitor as well in CSBC setting. So no, this is fantastic. I think we are moving into very exciting times even in CSBC.
I agree. Yeah, of course.
So now thinking about data from Aerosens and Aeronode, I think one of the challenges is, again, Aerosens showed that triplet therapy in all comers is better than doublet therapy with docetaxel doublet, and Aeronode suggests that darolutamide doublet is better than single agent ADT. So I just want to get your final thoughts on how you reconcile this data of where to use triplets, where to use doublets.
Personally, I wish a trial would combine the two, because one of the questions is how important is the docetaxel for some of the lower risk individuals, and can you compare that group to those who don't get double, so triplet therapy versus doublet therapy with darolutamide in low risk individuals. I think that to me is a question, is there a benefit to docetaxel? I don't think that's really been answered by any study yet. But
of course, I think if there is any role in my practice with docetaxel is in the high volume, high risk disease, and never with single agent ADT. If that patient is fit enough to handle docetaxel, in my practice, that patient is fit enough to handle doublet therapy. So it's going to be always triplet. So not really tried ADT with docetaxel personally, because there's no point in that, right? If you can't handle it, he can't handle even docetaxel, right?
Much the same. The triplet regimen, certainly for high volume, high risk disease and good performance status patients, I think that's considered the standard. Other than that, it's shared decision making for the other group there on whether they're doing triplet or doublet. And I really don't use ADT alone or recommend it that often for patients.
Yeah, I think all of us kind of agree that doublet is at least the standard of care, ADT plus NHT, and think about adding docetaxel in patients where we see fit high-risk patients. When you are using a doublet treatment option. How do you pick between, darolutamide, now that Aranort data is here, or enzalutamide, abiraterone, or apalutamide? All of them are approved.
Yeah.
How do you make the decision? It's a tough one.
Yeah, it is tough. I have my personal biases for darolutamide or apalutamide, particularly for the lower side effect profile, the lower CNS penetrance of darolutamide. But of course, we'll have to wait for the FDA to approve, this to be able to use that, first line. But otherwise, I'm usually going to apalutamide, or a lot of it has to do with financial toxicity or just looking at, other side effects or comorbidities. So someone with cardiovascular disease or hypertension, I might shy away from, abiraterone unless that's the only one that we can afford.
Yeah, in general, abiraterone is much more covered, and also slightly higher volume disease or more aggressive disease. Again, based on old doc can be taught new tricks, I guess. Still using more abiraterone where I need to, especially higher risk disease. Low volume, low risk, I think either of the other two options Dr. Cherington has mentioned is very reasonable and well tolerated, actually. So.
Yeah, my preference is for darolutamide or apalutamide when we're looking at things. The abiraterone, the prednisone can be challenging, but sometimes it's a cost concern because it's generic now.
Yeah.
So we use a bit of each in different situations, depending on the patient, what other medications they're on, what their comorbidities are.
Yeah. So I guess, we all agree that there is little to choose in terms of efficacy between these drugs. So it's really the patient profile, access to treatment, which helps us determine which of these agents to pick. I think darolutamide is unique in the sense that it has no CNS penetration,
Yes.
and with the Aranort data again,
Yeah.
the side effect profile was actually pretty exceptional. It really doesn't add much toxicity. So no, this is great. So I think that was it for our castration-sensitive prostate cancer discussion. And the summary statement, what we want to, our takeaway message here is that, the era of single-agent ADT is pretty much gone. Based on, conventional scans, the risk stratification helps us to think about, whether we use doublets or triplets. Most patients are, they should be receiving NHT doublets with, especially in synchronous high volume patients, and anybody who wants to be treated aggressively and can tolerate chemotherapy, triplet therapy is the best treatment option. And I think moving forward, genomics is likely going to play a role. Right now, there is no guideline-based evidence to use genomics to do this risk stratification, but just thinking through these high-risk mutations, the tumor suppressive gene expressions and ASPOP mutations can definitely seem to be where the future is moving. And also, I think HRR trials are also coming.
So another great summary, by the way, Dr. Riaz. Another pearl of wisdom, or what I've seen in my practice, is this 50%, right, under treatment or single agent treatments. Even though I'm an oncologist on record, I have quite a bit of this population, especially this elderly subgroup or still fit. They follow the urologist. The treatments are at the urologist. So I don't cross lines and say, let me add this. So I probably will be in one of your 50% there, hey, I think we have you there, but you're not admitting to us. I'm admitting on camera, I guess. So we just educate them and kind of give our recommendations, but we let the urologist keep treating those patients.
And underutilization of the bone modifying,
Right.
Yeah, I think it becomes critical in castration-resistant disease.
In castrate-resistant, not castrate-sensitive so much, but in castrate-resistant disease where they've been on ADT for a long time,
Yes.
and they have extensive bone metastases, it's something that should not be forgotten.
Absolutely. It's going to come big time in our CRPC discussion, so thank you for bringing that up. And and I agree that all of us have those patients,
Yes.
where for whatever the reason may be, we are still using single agent.
And wouldn't necessarily change if it's working at this point. If they've
course,
been
yeah,
on
that's
it. Obviously,
very important.
these are patients we inherit, and if they have a very good PSA response,
Why add now?
you consider whether a break from ADT or not, but you certainly don't escalate therapy without a reason to.
Right.
Thank you for your pearls in real world practice. Thank you so much.